Good afternoon and good morning, everyone.
Yeah.
Thank you for joining this conference today. Let me introduce myself. I am Shiho Tajiri, a dentist in Kyushu University Hospital. I will join this conference as a moderator.
Yeah.
Let's talk with you. Professor Incision, please give us a comment as opening remarks.
Okay. Hi, nice to see you. Dr. Yoshizumi, mentor of Dr. Mohammed Elshawy at Kyushu University Hospital. Actually, we call Mohammed, so we call Mohammed. He came to Fukuoka in last October, and since then he worked very hard to assist our hepatobiliary surgery and the living donor liver transplant. And furthermore, he worked on research work and wrote 2 papers. One is already published, and another is under review. So unfortunately, as you know, COVID-19 has affected his time in Japan.
Yeah.
I think it was very hard for him. And moreover, completely different cultures between Egypt and Japan. And I think he spent hard time because a small amount of halal food in Fukuoka. So, you know, he became very skinny. But anyway, I'm sure Mohammed did his best under this limited situation. So I'm very looking forward to hearing his report today. All right, thank you very much.
Thank you, Priyo.
Thank you very much. Would you introduce yourself in Egyptian members? Please give us a comment and your name or member in Egypt.
Again.
Yes, your name and the short comment.
You asking about member of
of the meeting, right? So every member can introduce himself.
Oh yes, okay.
So starting by Professor Dr. Hani.
My name, yes, I am Hani Saeed, professor of hepatobiliary and liver transplantation in Ain Shams University. In Ain Shams University, we talk about around 100 cases of liver transplantation, living donor liver transplantation per year. Okay.
Thank you very much.
Okay.
Please introduce yourself, other member in Egypt.
I don't see who is joined. I think Dr. Hatem Saber, lecturer of hepatobiliary and pancreatic and liver transplantation, actually involved. Dr. Ahmed Alewa, which is part of the liver transplantation at the National Institute of Liver of Hepatobiliary. Okay. I think Muhammad Abdel Razik, associate professor of liver transplantation in Ain Shams University. I didn't see who also is involved in this meeting.
Dr. Ibrahim Magid is also.
Dr. Ibrahim Magid actually it is an lecturer of hepatobiliary and pancreatic and liver transplantation in Ain Shams University. Who also Dr. Muhammad?
Sure
you can introduce it. Yeah.
So as the Professor Dr. Hani Said said, Dr. Hatem Said, my colleague is Dr. Hatem Said, Dr. Ibrahim Magid, they are lecturers of hepatobiliary surgery and liver transplantation in Egypt. I think also, I'm not sure. And Dr. Ahmed Alewa, he's a consultant of HPB surgery and living donor liver transplantation at NRMT.
Yes, one of the Ministry of Health institution of hepatobiliary and liver surgery.
Is yours?
Okay.
Dr. May Hawi, she is actually my wife, and she is a lecturer of assistant lecturer on clinical oncology at Kyushu University. I'm not sure. One from Japanese side, from the ESIB and from the BINKO International, can introduce themselves as well.
Yeah, okay. Hello, this is Dr. Hani Mahmoud, the cultural attaché at the Embassy of Egypt. We're joining from Tokyo, and with Professor Hani Elshimi, our cultural counselor.
Yes, I'm Hani Elshimi, Cultural Council Office Manager for the ECB here, the Embassy of Egypt in Tokyo. Thank you very much.
Thank you very much. Today's presenter is Dr. Elshawy. Please start your presentation.
Yeah, go ahead. So from the Far East to the Middle East, I'm from the Japanese flavor. Greeting to all of you. I'm Mohammed Elshawy, lecturer at Kyushu University, and I'm visiting fellow in HPB, surface and LDLT at Kyushu University Hospital. And I'm today reporting the training summary of the Egypt HRDP OGT on-job clinical training for HPB service and the minimally invasive HPB service and living donor liver transplantation at Kyushu University Hospital. And this is my disclosure. Thanks for the Ministry of Higher Education, Scientific Research, Cultural Affairs, and the Mission Sector for the educational scholarship. And thanks for the ESIB office in Japan for organizing and supporting the training program all through the years for me and for my colleagues. So this program was part of the Egyptian-Japanese Education Partnership Human Resource Development Project. It includes a one-year hands-on surgical training at Kyushu University Hospital, Fukuoka City, Kyushu University, Japan. I would like to express my sincere gratitude for Professor Mori, Chairman of Surgery and Science Department, for giving me the opportunity to join Surgery and Science Department family. And thanks also as continuous for Professor Dr. Shizmi, the head of HPP service, for his mentorship among his prestigious liver surgery team. The discipline of my training, I just said, service and living donor transplantation. Thanks of course for all the prestigious surgery department staff members who helped me all through the training period. Where we are for my colleagues in Egypt, this is the Japanese map, and this is Kyushu prefecture in the most west of Japan, and where is the Fukuoka city in the most north of the prefecture, and where Kyushu University Hospital is located in the most north of the Fukuoka city. Thanks for the International Medical Department, the TEMDEC Center for organizing the conference, and the OVIX Center for organizing and providing training of the year. So my training was hands-on training all through the year at Surgery 2 Department HPP team, and I joined Surgery 1 Department as an observer in the last 3 months of the training for minimally invasive pancreatic surgery. This is the outline of my training modules. It includes surgical training, operation statistics. I attended all through the year, surgical experience, endoscopy course, and research experience. For the surgical training, so I will present the operation statistics that I attended throughout the year. I have been engaged throughout the year in a large volume of HPP surgery, through which I gained a lot. And I have been assigned and scrubbed in a variety of operations. HPP service. So this chart demonstrates the total number of the operations attended, about 247 operations, a slight decrease during the era of the coronaviruses occurred, but not so much in decrease. As this chart demonstrates the number of operations per group. So at my group, HPP service under mentorship of Dr. Shizmi, it's about 200 operations. In the other groups, about 40 operations. So this chart demonstrates the operations attended by disciplines as well as my role during the operation. Total number of operations I scrubbed in was about 52 operations, mainly as second, third assistant, sometimes as a primary assistant, and I was allowed to do some components of the surgeries as well. For hepatectomies, more than 50% of the hepatectomies cases were done laparoscopically, 30% were open, conversion rate was about 4%. As by my role during the hepatectomies, open, laparoscopic, or other hepatectomies is shown in this chart. So I attended about 35 cases of pancreatectomy procedures, mainly at HPB2 liver team, 25 operations, and others that mainly focus on the minimally invasive pancreatic surgery at HPB Surgery 1 department as an observer.
This is chart demonstrate the pancreatic pave procedure as by my rule. So along the 35 operations, I was scrubbed in 7 pancreatic pave procedures that add to me a lot of experience in this field. For 42 liver transplant procedures, 35 were adult cases and 7 were pediatric cases, living donor liver transplantations. By graft type, main 45% was a extended lobe plus chorate graft, 40% were right lobe graft, and 7 cases, about less than 10% extended lobe minus chorate, without chorate. For the pediatric, 5 cases were left lateral segment and 2 cases were monosegmentectomy. Among the living donor liver transplantation, about 40% of the cases were ABOi incompatible living donor liver transplants. I would like to invite all of you to the Sakura flavored spring in the amazing green landscape at Ohiro Park. This is one of the Fukuoka landmarks, actually. So let's move now for the second module, surgical experience I have gained here at Kyushu University Hospital. So this is the outline of this surgical experience among the living donor liver transplantations, the hepatectomies, and the pancreatectomies as well. I will start talking about the autologous venous graft used in the living donor liver transplantation. So among the major prerequisites for technically successful living donor liver transplantation in both modified right lobe and extended left lobe is ensuring good outflow to prevent the graft congestion, as a graft outflow occlusion and congestion can lead to suboptimal graft dysfunction and subsequent catastrophic small for function size syndrome. At Kyushu University Hospital, they adopt creating a wide venous opening for the hepatic venous outflow, either for the modified right lobe graft or for the extended left lobe chorate, using autologous venous grafts, either from the recipient, internal jugular vein, external jugular vein from the neck, or recanalized umbilical vein if well developed in the CT evaluation preoperative, or from the inferior mesenteric vein, which is rarely used, and from the donor round ligament vein as well. After reperfusion, the presence of triphasic pulsatile wave on the Doppler is a sign of perfect reconstruction. I'll show some cases of that for illustration. So this is one case of modified right lobe graft in which V8, V5 were reconstructable in the graft. So the first image showing the graft right hepatic vein, and then the graft V8 and 2 V5 were present in this graft. An interposition graft using the recipient internal jugular vein to drain the V5, and an interposition graft using external jugular vein for draining V8. All have been smoothed at one edge to the right hepatic vein and other edge to the donor round ligament as a one venous cuff. And this is the final appearance of the venous cuff using the donor round ligament vein anastomosed to the right hepatic vein, internal jugular vein draining V5, external jugular vein draining V8, and as a common triangular common orifice with a 7-0 proline to be anastomosed with to the triangular orifice in the recipient IVC. Another case is a modified right lobe graft in which reconstructable V8, V5, and inferior right hepatic vein. This was an interposition graft using the recipient internal jugular vein also to drain the cranial as well as the caudal V5. And an recipient portal vein actually was used as an interposition graft to drain the V8. And then the donor round ligament vein was used as a patch for draining the graft in inferior right hepatic vein as well as the right hepatic vein and all of the interposition grafts used before. So one venous opening is created and drained to the triangular orifice to the recipient IVC as well. This is another case of extended lobe plus chorate lobe graft, in which middle hepatic vein, umbilical fissure vein, left hepatic vein, and chorate vein were present in the graft. So first, the venoplasty was done transecting the septum between the middle hepatic vein and the umbilical fissure vein by the CUSA and suturing the adjacent walls. And then reconstruction was done using the donor round ligament vein as a wide venous cuff, draining all the graft outflow to the recipient middle and left hepatic vein. So this is the final appearance of the common outflow graft. This is the left hepatic vein, umbilical fissure vein, middle hepatic vein, and chorate lobe vein, all anastomosed by wide venous opening to the venous by a venous cuff to the recipient middle and left common orifice. This is another case of modified right lobe graft in which preoperative CT evaluation showed a well-developed para-umbilical vein in the recipient. So the para-umbilical vein was used as an interposition graft. A leakage test in the bench table was done. And then the recipient paraumbilical vein was used as an interposition graft, draining the V5 of the graft. The donor round ligament vein was used as an interposition graft, draining V8. The rest of the round ligament was cut and used as a wide venous cuff, reconstructed and utilized for draining right hepatic vein, V5, interposition graft, and V8 as well as a single common arms. A second module has been exposed here at Kyushu University is the minimal incision donor hemiliver graft procurement. So for the living donor liver transplantation, the donor safety comes with the highest priority, and every effort should be made for the physical and psychological well-being of the living donor. Many approaches for the living donor liver donor hepatectomy was described. Conventions of coastal incision, G-shaped incision like this. Laparoscopic and hand-assisted laparoscopic, although described, however, safety is not well established all over the teams. And it also had some complex and expensive, less feasibly applied, and some difficulties in managing intraoperative emergencies. At Kyushu University, they advocated the use of the small upper midline excision as a safe standard approach, safe and feasible, less invasive surgical technique. And also critical stages of the procedures like retrohepatic venous dissection, hilar dissection, parenchymal dissection are done under direct vision. So this is the incision, about 11 to 13 centimeter long, depending on the donor abdominal status and the graft size. And then retraction of the upper abdomen and the middle abdomen is also applied. Another experience I have been exposed is the portal hemodynamic management of the recipients. So for another major prerequisite for technically successful LDLT is normalizing the portal inflow hemodynamics to prevent small for function size syndrome or portal seal phenomena. So at Kyushu University, we continuously monitor the portal venous pressure by a centrally, preferably inserted central catheter, and 4 important time landmarks that determine the management strategy at laparotomy, before graft reperfusion, after graft reperfusions, determine the portal hemodynamic management strategy, and last minute before closure of laparotomy, portal venous pressure management. Target portal venous pressure is to be between 15 and 20 millimeter mercury. They also assess the portal flow after establishing the hepatic artery blood flow using ultrasonic transient time flow meter, and the target portal venous flow is about 1 liter per minute. So this video show demonstrate the technique of portal venous pressure monitoring at Kyushu University group. So first, they expose, this step is done just after laparotomy and exposure of the abdomen. So they first identify a terminal jejunal vein. After identifying a terminal jejunal vein, they start preparing it for catheterization by applying a 3-0 vicryl stitch or monocryl stitch around the vein and keeping it ready just after applying the catheter. So here they are start introducing the catheter in the terminal jejunal vein. It will just appear within a few seconds. So they introduce the catheter in the terminal jejunal vein, and the assistant fix the vicryl stitch around the catheter. This is the peripherally inserted central catheter. So the catheter is kept all through the operation to allow continuous monitoring of the portal venous pressure to determine the best management strategy according to the portal venous pressure. So now he fixed the catheter. After fixing the catheter, the surgeon puts a hemostatic material over the catheter and the surgical field, so that to keep in perfect hemostasis until the end of the operation. So this will be masked inside the abdomen all through the operation. So So now applying the hemostatic material, and then put it inside the abdomen and go for the hepatectomy stage. So at Kyushu University, the basic strategy is to simplify and normalize the portal vein hemodynamics by two major components: preventing portal seal through the ligation of the major port systemic shunts, and pre-operative CT evaluation for the shunts more than 1 centimeter to be routinely ligated during the operation. The tactics to approach these shunts for gastroesophageal shunts, they used in-block stable division. For the splenorenal shunts, they follow the left renal vein directly to identify the splenorenal shunts. They also normalize the portal inflow by portal vein decompression according to the portal venous pressure measurements. They use splenic artery ligation just before the graft implantation if the portal venous pressure is more than 20 millimeter mercury. And splenectomy can be used either before or after graft implantation according to the venous pressure measurements accordingly. For splenectomy, they use a vessel sealing device for dissection around the spleen and stapler division of the splenic hilum to decrease the time and decrease the bleeding incidence during the splenectomy. The last module in the living donor liver transplantation is the ABO incompatible living donor liver transplantation. So it takes about 15 years for the Japanese experience to develop and establish the protocol for ABO incompatible living donor liver transplantation. Igawa et al. 2007 has published the results of these 15 years, which show an increasing level of ABO incompatible liver transplantation throughout the years till reaching the peak at 2005. It passes through main 3 stages. So before 2000, they use a combination of plasmapheresis and splenectomy. In these cases, after 2000, there was an introduction of the graft local infusion using some drugs to be continuously administered for 3 weeks through the portal vein, hepatic artery, or both of them. After 2003, rituximab-based therapy was introduced, either with or without splenectomy. So survival curves of the 3 groups is demonstrated. So better survival was obtained after graft local infusion, and much better survival also was obtained after rituximab-based therapy. At Kyushu University, they introduced the ABO incompatible living donor liver transplantation as early as Japan. However, they abandoned the graft local infusion because of the catheter-associated complication, and they depend since 2003 on rituximab-based therapy. Rituximab-based protocol 3 weeks before the transplantation, and plasma exchange used periodically in the week before the transplantation with a cutoff of the isoagglutinin titer to be below 64. Mycophenolate mofetil is introduced 1 week before the transplantation, and every case was done with a splenectomy. However, experience built up some changes, so the most recent protocol nowadays is established to be rituximab-based therapy 3 weeks before the transplantation. Plasma exchange is used to reach a titer less than 512, so the cutoff limit of the titer is increased to 256 and sometimes 512 in some cases. They exclude splenectomy as a routine maneuver in these patients, and IVIG is rarely used as a rescue therapy if antibody-mediated rejection is encountered. No preference for any donor-recipient blood group matches at Kyushu University Hospital. Clinical course of ABO incompatible is comparable to the ABO compatible. Possible complication is an antibody-mediated rejection, which can be manifested either through deterioration of the liver functions or through refractory cholangitis after the operation. At Kyushu University Hospital, I attended about 42 cases. 40% of the cases were ABO incompatible liver transplantation, with a very comparable survival, and almost no case where has developed antibody-mediated rejection post-transplantation. This is another site. Is Ikino-Matsubara is another park which is very nice in Fukuoka, enjoyed with some Japanese, Egyptian friends actually. So next experience I have been exposed here is a minimally invasive pancreatic surgery. However, this was at the surgery 1 department as an observer. I will briefly talk about that. In the port design principle in the laparoscopic pancreatic duodenectomy is almost the same as the upper GI surgery. In the laparoscopic distal pancreatectomy, the port design is shifted slightly to the left side near the midline in this way. The surgeon is standing on the right side of the patient, the assistant on the left side of the patient, and the cameraman, telescope man, is in between, in the French position, in between the legs of the patients. An objective laparoscopic distal pancreatectomy was difficult to be obtained, and hence difficult score was introduced at Kyushu University Hospital using the type of the operation: pancreatic resection line, tumor close to the major vessel, tumor extension to the peripancreatic tissue, and left-sided portal hypertension for difficulty index from 1 to 10 to assess the preoperative difficulty of the operation. So moving to another discipline is the ICG applications in the hepatobiliary service. For ICG, it can be used either for functional assessment of the future liver remnant or for imaging applications. So for preoperative assessment of the future liver remnant, we will first talk about this. So ICG retention test 15 is used for preoperative assessment of the liver function and determining the future liver remnant based on the idea of the faster clearance of the ICG will show a lower retention percentage at 15 minutes, which indicates a better liver functions. So they use the McCauchy decision tree criteria based on normal bilirubin and no ascites. So ICG test can be used by giving the ICG for the patient at a dose of 0.5 milli per kg 2 days before the operation. According to the ICG retention test results, either major hepatectomy is done if ICG retention test is lower, or ICG retention test between 30 to 40%. Limited resection is applied in these patients, as limited as possible. Laparoscopic liver resection was introduced. However, it was very difficult to obtain some information because of the difficult without palpation as in the open surgery. Hence, ICG imaging application is also used in the laparoscopic liver surgery and is open and in open surgeries as well. So this is the telescope used, and this is the ICG ampoule shape. So for imaging application of the ICG, it can be used for by near-infrared ICG fluorescence to accurately determine the tumor site, securing surgical margin during the resection and excluding ischemia of the remaining adjacent liver segments. Also, segmental mapping and intraoperative cholangiography are used for ICG application. However, this is not used at Kyushu University also. So the basis of the ICG application depend on the 3 phases of the ICG after intravenous introduction. The first phase is the fluorescent angiography, in which it appears 20 to 30 seconds after ICG injection, which depends on the concentration of the ICG in the tissues after IV administration, and it's determined by the intravenous distribution. The second phase is the fluorescence cholangiography, and it takes about 20 to 30 minutes until the ICG is excreted in the bile by the liver, up to 1 hour. The third phase depends on the late post-clearance phase, which is 2 to 3 days after the ICG administration, depending on the liver functions. And here, it can be utilized for the identification of the tumor. For HCC cells, it can take up the ICG as a normal hepatocytes. However, it cannot excrete the ICG. Hence, the total fluorescence pattern appears, homogeneous fluorescence appears for the HCC. For the liver metastasis and poorly differentiated HCC, the perihepatocytes showing disturbed functions. However, the liver metastasis and the poorly differentiated HCC cannot uptake the ICG, so a REM fluorescence pattern appear in these cases. I will show you some examples. So this one case of segment 8 tumor. This is the tumor in the preoperative CT evaluation. Laparoscopic evaluation, the tumor bearing segment resection margin is applied during laparoscope. The ICG is used to observe the liver surface during the transection, and the removal of any tissue with an ICG fluorescence was completed during the transection. So this is the liver segment after the transection. The specimen after the resection showing homogeneous fluorescence. And they used also intraoperative ICG injection to determine the resection margin of the liver, resection margin if there is any ischemic margin or not. Another case of liver metastasis in which accurate tumor localization is also used. So this is a case of colorectal liver mets in segment 8. So ICG evaluation to visualize the planned area of the resection showing a REM fluorescence pattern. And this is the specimen after the resection. So the specimen showing a REM fluorescence pattern after being resected. And this is the resection area, the resection surface, resection liver surface. And also evaluation of the peri-resection margin to evaluate for ischemia of the ischemic margin by intraoperative administration of ICG. So the last image depends on the character of the ICG fluorescence angiography character. Another discipline I've been exposed here is the laparoscopic liver resection. So, an international position on the laparoscopic liver resection was announced in 2008 in this statement. For the surgical difficulty of laparoscopic liver resection, it's highly subjective and depends on many factors, and hence it warrants the use of an index for surgical difficulty following the corresponding roadmap for building surgical skills. So Bain et al. Proposed an objective laparoscopic liver resection difficulty scoring system which predicted the technical difficulty of the various laparoscopic liver resection preoperatively. It utilized a score from 1 to 10 in two levels, 10-level indices and 3-level indices correspondingly. The 10-level indices from 1 to 10, and correspondingly 3-level indices either low, intermediate, and high. And landmark operations is assigned to every category difficulty, and hence it can evaluate the difficulty of the laparoscopic liver resection preoperatively. It utilizes the tumor locations, the extent of the liver resection, tumor size, proximity to the major vessels, and liver function for determining the difficult score. I will show some cases through my experience. So for right lobe tumors in segment 8, either anteriorly on the posterior superior or posterior inferior segments of the liver, a dual handling technique approach is used. The patient position is in semilateral position. The degree depends on the segment to be resected. The right hand of the patient is situated, is moved toward his head in that position, and the patient is controlled safely using the vacuum mattress and 2 dashboards. Surgeon stand on the right side of the patient. The assistant stand on the left cranial side of the patient, and the cameraman is standing next to the assistant on the left side of the patient. The port design principle in these cases, usually 2 working ports in the right side of the patient, mostly in the right, after introducing the telescope in the supraumbilical position, about 12 centimeters below the costal margin, depending on the abdominal status of the patient. 2 working ports are introduced on the right side, maybe in the right anterior axial line and posterior axial line, and 2 assistant ports introduced in the epigastrium and right parietal line, and bringing through a left midclavicular line 5mm ports. For segment 8 and posterior part of the segment 4, a slight change can be according to the abdominal status after insufflation in the designation of the port. For the posterior superior segment 7, an intercostal transthoracic port is usually needed in these cases. So I'll show you some examples. So this is segment 8 tumor. The port design as previously described. This case, laparoscopic difficulty scoring system was 4. And this is the ICG appearance of the tumor intraoperatively. So a red fluorescence is shown here because this is a metastatic liver disease in segment 5. So this is the post-resection area, and this image showing the ICG to evaluate the ischemic margin of the resection line after resection. Another case of segment 8 ventral tumor in which an HCC recurrence. So this is a port designation, 2 working ports and 2 assistant ports, springing through a left midclavicular port and telescope in the supraumbilical region. The difficult score of this case was 9. And this is the ICG appearance of the intraoperative, and this is the resection line applying the hemostatic material after resection, and the post-resection view after the resection of the specimen. Another case of laparoscopic S-segment tumor. Here I would like to note the intercostal transthoracic port that is usually needed in this type of tumor in this segment as a working port. So for left lobe tumor, they use the same approach as a dual handling technique approach. However, some changes with the patient in the supine position. The surgeon usually stands on the left cranial side of the patient, cameraman next to the surgeon, and the assistant on the right side of the patient. First trocar is usually in the umbilical by Hassoun technique, laparoscopic inspection by 30-degree telescope, establishing CO2 pneumoperitoneum and maintained as 10 to 12 millimeter mercury. As I described, the working ports and the assistant ports, and the bringing usually done through a right 5mm port in the anterior axial line. For segment 2 tumors, a slight change in the port design sometimes applied in this manner. So some examples. So this is a segment 4 ventral part of segment 4 tumor, and the difficult score of this operation was 4. And this is the ICG fluorescence appearance after resection, and this is the port designation. Another case, segment 3 subsegmentectomy was applied, the port designation, so the telescope, two working ports on the right side of the left side of the patient, two assistant ports, and the Pringling through right side 5 millimeter 5 millimeter port, and this is the post resection area. So another module I have been exposed here is I have been allowed, thanks to the support of Professor Mori and Dr. Shizmi, through the Kyushu endoscopy course, through which I attended a condensed endoscopy training course that was partially sponsored by Surgery and Science Department for a dry and wet lab training. And through this course, I had been exposed to enhancing technical tips in laparoscopic surgery, and I have been exposed to the Da Vinci robotic simulation training as well. Another experience is which is a very good experience. It was the research experience I've been exposed here. So I was allowed, as Professor Shizmi introduced in the beginning, to publish a case report, namely post-transplant inflammodulation for early allograft dysfunction after living donor liver transplantation. I have been writing. I also, under his mentorship, I have written an original article that has been submitted recently. So I will give a brief description of the case report that have been published. So this addresses the management strategies of small for function size syndrome after LDLT. So for portal vein modulation strategies after, before or during or after LDLT is still a controversial issue. So the case that was assigned to me, the 43-year-old female patient in the stage liver disease had an ABOi incompatible living donor liver transplantation, with a graft recipient weight ratio about less than 0.7%. After graft reperfusion, portal venous pressure was about 20 millimeter mercury. Portal venous flow was relatively low, as low as 512 milli per minute. Post-operatively, so in this operation, there was no portal vein modulation strategy was being applied, giving the relatively low portal venous flow after reperfusion. However, post-operative course was not smooth. Post-operatively, the portal flow was as high as above 30 centi per second. The patient developed increasingly amount of ascites and hypercoagulopathy, and coagulopathy, and increasingly serum bilirubin. Splenic artery embolization was decided on post-operative day 10, after which clinical improvement was encountered, a decrease in the amount of the ascites, gradual decrease in serum of the serum bilirubin, as well as the improvement in the coagulopathy, as well as improvement of the ultrasonic measurements of the portal venous flow. So this slide demonstrates the ultrasonic measurement of the portal venous flow before and after embolization. So before embolization was above 30 centi per second. After embolization was about 20 centi per second. So this is the angiographic imaging before embolization and just after embolization. And this is the preoperative CT evaluation before embolization and CT evaluation after embolization, showing the splenic infarction due to the partial splenic artery embolization. After 2 cycles of major revisions, which added to me a lot of scientific input and a lot of scientific discussion with the prestigious liver surgery team members, finally it was published in the surgical case report journal, and there was a great step in the collaboration between Kyushu University and Ain University that I'm looking forward to for more peer review research collaboration to be continued after that. I was exposed to Japanese flavored culture and food, invited by my dear mentor for a sumo game, which was a very nice experience. I have been exposed, and these are the members of the team, and I have enjoyed some outing with the team members. And finally, I'd like to thank Professor Mori and Dr. Shizmi and all Surgery and Science Department and Liver Surgery team for the nice experience I have been here in Japan. And we'd like to invite them to enjoy an Egyptian flavored, pleasant and memorable experience with sightseeing in Egypt in the future, maybe after the coronavirus. So thank you for your attendance, for all of you, and I'm looking forward to your comments.
Very much for your interesting presentation. I'm happy to hear that you can get a lot of knowledge and enjoy your stay in Japan. Do you have any question or comments?
Maybe you are muted, Dr. Hani. You are muted. please unmute your mic.
Okay. At first, I would like to thank you, Dr. Mohammed, for your great job. Actually, it's a very hard time and a very long time. You have a lot of experience. You are very lucky to be present in Kyushu University with this very big activity in 1 year. Thank you for all your professors there for their support and for their support for you to get this very nice experience within 1 year. It is a lot of job, a lot of activity. Thank you for all your professors. I think a lot of debate, a lot of difference between Egypt and your center. I will ask about the results of ABOi incompatible, which is very interesting for us because actually we have never to do any case of ABOi incompatible. I will ask about the survival, the patient and the graft survival, especially in adults. I think in pediatric the results is very good. I'll try to ask about the results of ABOi incompatible in adult. Number two, I will ask about the differences between synthetic and autologous graft. Actually, in Egypt, we have a bad experience with the autologous graft, so we have a very good patency rate with the synthetic graft. I wait for your response.
For my experience, could you? As for my experience at Kyushu University, I have been 40% of the cases were ABOi incompatible living donor liver transplant, and the survival rate was very comparable to the ABOi compatible living donor liver transplant. Using the established protocols that I just mentioned in the report summary, and I'd like to introduce also at my institution in Egypt. It would be my pleasure. Maybe Professor Shizmi would like to add something from his experience. He will be more experienced in something like this if you would like to add something.
Yeah, actually, outcome of ABOi incompatible living donor liver transplant is 5-year survival is around 80%.
Yeah,
so,
perfect.
It's almost comparable to other identical or compatible transplant.
With the attack of rejection or antibody-mediated rejection, need more care, health care, need more admission in the hospital, long time for treatment. Is there any difference regarding hospital stay, post-operative course, especially in the perioperative period?
Actually, not really. Actually, almost the same situation, especially after transplant. Before transplant, the patient has to get rituximab 3 or 2 weeks before transplant. But that's it. That's it. And we try to maintain mycophenolate.
Yeah.
To suppress
before
transplant. Before transplant, 1 week.
Yeah.
Before transplant and after transplant as well.
Okay. Synthetic graft and the autologous graft. There is no difference.
That graft is not covered by insurance in our country, and it's very expensive, right? So we can take from the patients we are using. But synthetic graft is one of a good choice, I think.
Okay. About the case report you have done, you make an inflow control after 10 days by splenic artery embolization. Within these 10 days, there is no insult on the graft from the high portal pressure.
Actually, there was an insult, and there was a slight delay in the, but not so much delay, maybe 2 days in the decision, but it doesn't make a great change. So after established increase in the bilirubin level, deterioration of the coagulopathy state, and increasing the amount of ascites, a splenic artery embolization was finally decided, and I think it may be within the right time. Post-operative course of the patient showing gradual improvement, and I was following up with the attending surgeon, and the patient was smoothly discharged from the hospital 1 month after the operation, which is 20 days after the splenic artery embolization, in a smooth condition. It was a very nice experience. I have observed the drain removal when the ascites amount decreased below 400 cc, and coagulation, INR and platelet levels returned almost to the normal levels. And also the bilirubin levels was down maybe less than 5 millimeter. Serum bilirubin was below 5 millimeter.
Okay.
Yeah, actually, let me tell you something. Actually, small fossils graft syndrome usually occur more than 7 days after transplant, because graft regenerates after transplant, and it becomes firm, hard. So blood pressure is elevates high after regeneration. So that time period is around 7 days.
Okay. And splenic artery embolization is equal for like splenic artery ligation. There is no difference regarding post intervention complication like infarction or abscess formation, especially in immunocompromised patient.
Yeah, actually, splenic artery ligation is not such a hard technique, so not a different difficult technique. So we usually always do, and usually no complication of this technique. But with splenectomy, patients have some complication like pancreatic fistula, or we call OPSI, overwhelming post-splenectomy infection, but very low frequency, about 2 or 3%.
Okay.
Another parameter in this case actually was the borderline portal venous flow after transplantation. So portal venous flow is usually kept at Kyushu University, the target to be above 1 liter per minute. In this case, actually, despite the high portal venous pressure, portal venous flow was below 1 liter per minute. So this is what's questionable. How the graft will looks like.
Tolerate,
how the graft will tolerate. It was a questionable. So the decision was to leave the graft to decide what is the course post-operative. Is it splenic artery embolization being feasible technique? Or maybe it will need some sort of shunt ligation, also angiographically using the Barrow technique. Balloon retrograde occlusion of the splenorenal shunt.
Okay. Lastly, I ask about the portal pressure measurement during the liver transplantation. You measure it from peripheral. One of the terminal jejunal veins. Actually, in Egypt, we pressure from the main portal of the recipient side. I will ask about if there is any difference regarding the central or peripheral measurement. For example, if you decide you will take an action if the pressure more than 20. This is in the peripheral. Is this number changed if we measure it centrally from the main portal vein? Actually, we didn't never measure the portal pressure from the peripheral. We usually measure it after graft implantation from the recipient side, the main portal vein. There is any difference regarding the target?
Okay, let me tell you. Actually, if you have to take the native liver very fast, I mean, you have much bleeding from the native liver, and you have to take it. And after that, you are clamping the portal vein. And if you monitor the portal pressure, you can decide whether you can still clamp or you should make a portal cable shunt.
Okay.
Before implantation. After implantation, as you know, portal pressure is very important. And sometimes, we are closing the portal cable shunt. Natural, closing. So yeah, like a renal portal, splenic renal shunt or something.
Actually,
All splenic
yeah.
renal shunt, and you know, you can monitor the portal pressure, and you know whether we can close such a splenic renal shunt or we should leave open.
Okay. Okay. Thank you, Dr. Mohammed. Thank you, Dr. Professor, my dear professor.
Okay.
Thank you, Professor Hani, for your comments. If any of the colleagues have comments, it would be also welcome. Dr. Ahmed Ali.
Please give us any comment from the Embassy of Egypt.
One of my colleagues will give a comment.
Okay.
So Dr. Ahmed Ali wants to give a comment.
Oh, thank you so much for your great invitation. I have only one question.
Would you like to introduce your experience also as well? So introduce yourself and experience.
So I'm Ahmed Adewa, consultant of HPB and liver transplantation at National Hepatology and Tropical Medicine Research Institute, Cairo, Egypt. Actually, I spent also 1 year in Japan, maybe last year, at Kyushu University School of Medicine. And I have also maybe near experience as regard ICG fluorescence technology in the field of HPB. And I have the chance to invite Professor Auki from Kyushu University and Professor Seyo from Kyushu University. And so we established our first workshop in Egypt as regard ICG technology in the field of HPB at National Liver Institute, Minimally University, Egypt. Maybe this was before the COVID pandemic, but after that, I think we cannot continue. My question about your biopsy protocol, because in our team, we do routinely time zero biopsy before closure of recipient to check ischemia, reperfusion, injury changes, pathological changes. Sometimes we take post-operative biopsy, but not routinely done. Some centers take biopsy post-operatively routinely after 6 months, 1 year, 5 years, different from center to center. My question is about your protocol as regard biopsy protocol post-LDLT transplantation. Thank you so much.
I'm not sure if we take
Okay.
biopsy.
Yeah, okay. About the protocol biopsy, we're not doing, actually. Before the, Hep C era, before, you know, we can overcome the Hep C, we did protocol biopsy for Hep C patients after transplant. But now, you know, if the just when the patients had elevated transaminase or something bad liver function, we are doing biopsy, but not routinely.
Not routinely. Thank you. Thank you so much.
Okay.
Thank you. If any of the colleagues, Dr. Hatem, Dr. Gamal Qasim, Dr. Ibrahim Magid, if any of the colleagues would like to have any comments, they will be more than welcome.
If not, may we just say, if not, we can just say at the embassy some comments.
No, Dr. Hani.
Okay.
Yes, please.
Okay. At first, in behalf of the ECB and the Embassy of Egypt in Tokyo here, I would like to thank very much Kyushu University, especially the supervisor of Dr. Elshawy. And we could congratulate Dr. Elshawy for his achievement during his staying in Kyushu University. He has very good outcomes. And I think, let me emphasize again, this is the second time just to meet with the team of the hospital in Kyushu University. And I would ask Dr. Elshawy to open the gate for the strong collaborations between Kyushu University and his university, which is Ain Shams University in Egypt, because there is a good opportunity right in a days to send some teams from Kyushu University to Ain Shams University. And I have seen and listen to Professor Hani from Ain Shams University as well. I think if we at the office right here can support this kind of MOU to establishment these collaborations, and me and my colleagues, Dr. Hanim, we can just support very much to establishment this kind of scientific and academic collaborations between both hospitals, in Ain Shams and the Kyushu University. This is, I would ask before Dr. Elshawy he leave travel back to Cairo, he have just to discuss with his team, and he can just let us know by email what we can do in the next step in order to be effective, you know, because as his, I was listening for his also telephone, he have been just telephone to me last couple of days, and he informed me he had a lot, and again, a lot of techniques and informations and so on. So again, I would ask him to transfer this kind of technology to his colleagues back once he back to Egypt as well. So this is, I would like to again, once again, thank you very much for all of you. Really, it is a good achievement, a good opportunity for us to listen what our teams regarding the on-job training protocols and proposals is going to be, you know, announcement again for 2021. And I would also ask Professor Hani from Ain Shams University and even Dr. Elshawy to nominate other people to send them in Kyushu University again in order to increase the number of the teams who has been gained the information from Kyushu as well. Thank you very much. Dr. Hani, maybe also.
Oh yeah, thank you so much. I'll echo what our director has just mentioned. Professor Hani mentioned that we really appreciate Kyushu University's efforts to give great opportunities to our doctors, Dr. Elshawy and Dr. Hanafi. Last month we could have the chance to listen to his presentation as well. Also, what we could understand now from Dr. Elshawy presentation that he was involved in around 197 operation as first assistant, which is, I think it's a great opportunity to a doctor to be involved in Japan, to be the first assistant in this kind of operation. So thank you so much again. And I would like to emphasize what Professor Hani has just mentioned, that it would be a great progress if we could have the next step, which is as I'm outside of the medical field, I could understand from Professor Hani Said said that we have some kind of bad experience with operation that, but in Japan you have like 80% survival rate, if my understanding is correct. If there is any chance to have this operation in Egypt, just to teach our teams there in Egypt how the Japanese experience go with this kind of operation, I think this would be a great opportunity to have this experience there in Egypt. And as Professor Hani mentioned, would like very much to support to have you professors there in Egypt, to invite you with the collaboration with Ain Shams University. If there's a chance to have the team there, I think this would be a great progress again, not only through Dr. Elshawy, but also for the Egyptian staff there, that I'm pretty sure that they would like to have this great experience with you. So, and thank you again for your great efforts. Thank you.
Sorry, let me add also the very important issues, which is nowadays the president of Ain Shams University is Professor El-Mitini. He is a liver transplantations, you know, and he's a very famous one. And I think he can just push this kind of collaboration very much, because I have the opportunity to talk with him all through the phone, and he is really kindly and support this kind of collaboration as well. Maybe Professor Hani can just talk with him and just to find the way how we can deal with this issue. You know? Thank you very much.
I have just one documentation. I don't say that we have a bad experience with the operation. We have a bad experience with a type of the graft. This is a technical issue.
Yeah, what
and
I exactly meant,
yes.
but as I have mentioned, I'm out of the medical field, so and I'm pretty sure
talk about one step in the operation,
and that, from them.
Okay, and we are already replaced with another type, and actually there is a difference between the Japan and the South and Far East and the European and the American school also support the use of this type of the graft. We use it. I don't say that we have a problem or a bad experience in Egypt. Okay. Number two, Professor Dr. Mitani is the very kind person. We have a very support for any to get any experience, especially from East and West actually. So I think it will be very happy to do this collaboration.
So thank you, Professor Hani and Professor Dr. Hanem, for your comments. And the support of the ESIP under your supervision and under your work is highly appreciated. And the success of this program wasn't have been accomplished without the support of the ESIP. Usually, the ESIP is usually following up almost every 1 month or 2 months about the situation and the status. And if there is something like a natural catastrophe or something occurring in Japan, they are just following up with us to be sure that everyone is safe here. And thank you for your following up and support for the program. And I hope further progress of the program can be achieved in the future. And we will arrange with my professor in Egypt and the committee, Professor Dr. Hani, and my colleagues to ensure that more colleagues will have a nice and a great experience. And I will ensure that the experience that I have gained and exposed here will be transferred. And maybe under supervision of Professor Shizumi, we are looking forward for further peer-reviewed research and collaboration. It will be a very nice experience as well. Just a correction, Dr. Hanem, it was 187 operations in total, but 50 operations scrubbed in. So about, I was, thanks to my mentor, Professor Shizumi, I was scrubbed every 1 week, almost in one operation. And this is a very high rate of scrubbing among the other team members. And thanks for his support. Not as a primary assistant, but second and third assistant. But these gains makes me gain a lot of skills and information. And maybe I would like to hear his comments about the skills, if you would like to.
Yeah, he became much better.
Thank God.
Can I have a little word, please? Can I have a little word, please?
Yes, sir.
Okay, thank you.
Go ahead.
Introduce yourself, Dr. Mohammed.
Yeah, my name is Mohammed Qasim. I'm a clinical lecturer of general and bariatric surgery at Shams University, Cairo, Egypt. Actually, I'd like to thank Dr. Shawi for his nice and extremely scientific presentation. I am very admired of his hard work within 1 year. I think he gained much information, knowledge, and experience about the advanced branch of HPB in your respectful university. I think he was a good image and a representative of our colleagues and our university. And I'd like to thank him very much for this. And as you know, Dr. Shawi, we are calling you in our university the scientific surgeon.
Thank you.
So this is his title within our friendship community. Secondly, I'd like to deliver my sincere and heartfelt regards and appreciation to your university in Japan and to your professors, because I can see clearly that you have received much and intensive support by them, ranging from clinical and surgical participation, as the embassy representative said, to research and some hands-on experience. So I can see that you were treated as if you are a Japanese native doctor. And this is very impressive that professors at Japanese university, I think it's Kyushu, has supported you so much and in that way, in that respectful way. And we are looking forward for more collaboration with other colleagues from our university. And I really thank you very much from my heart. Thank you.
Thank you so much, Dr. Mohammed, for your comments. Actually, Dr. Shizumi was treating me not actually as a Japanese surgeon, but I gained a lot of experience. So the best experience that I would like to express that maybe Dr. Shizumi has a comment on this, that I was dealing in the operation in a Japanese way. Maybe you have some comments.
Oh, yeah.
So I was almost naming the instruments in Japanese way, and even some Japanese words like kodasai, shotomate, hokaisyo, something like this. It was a very nice experience.
Yeah, he speaks Japanese very well.
Just inside the operation. After scrubbing, after I descrub, I think I know Japanese words.
Okay.
Finally, I would like Professor Hani to make closing remarks?
Thank you. Thank you for you. Thank you for you. Okay. Again, full thanks for your supervisor. Full thanks for the Japanese nation. Full thanks for the Kyushu University. Thank you for getting this opportunity for our colleague to get a lot of experience in a very important subject and a very different issues from your respectable university. Thank you very much. Thank you, Dr. Mohammed Shewi. We have a lot of hard time, a lot of hard work. You leave your family. You spent a lot of time, especially in the presence of the COVID pandemic. There is no, you have actually have a lot of hard time. I know that. I talked to you repeatedly in the last 3 or 4 months. So I'd like to thank you very much for your this hard work activity. I think you are very fortunately to be present in the Kyushu Hospital with this, a lot of this variety of the HPB surgery. Again, I repeat what the professor, what the Dr. Hanishimi say. We need to support the collaboration between the two universities, and even in the clinical experience and a lot of issue. We need some discussion from your professor to get your experience. Thank you again. Thank you.
Thank you very much. We are finished today. Thank you very much.
So
thank you. Thank you.
Thank you all very much for your attention and
Bye.
for your and thank you for the ACIP for their support and for my colleagues and all attendees. And thank you, of course, for Professor Yushizumi for the nice experience I have been at Kyushu University for 1 year. And I'm looking for further collaboration in the future.
Okay. Thank you.
Thank you.
Goodbye. Goodbye.
Bye-bye.